Welcome to the module of metabolic bone diseases. Obviously, when we talk about metabolic bone diseases, we have to understand the metabolism of the bone. And if you like to understand the metabolism of the bone, we have to understand the physiology, the components of the bone. But lucky for you, we've already discussed the constituents of the bone in the basics. So I'll just quickly review what those constituents are to wrap your head around this topic, and then we'll understand the physiology of the bone, and only when we have mastered that, we'll start discussing the pathologies of the bone in terms of metabolic bone diseases. And once you follow this step by step, things will become clear. Otherwise, you'll always be confused. And the reason for that is very simple. You see, in metabolic bone diseases, the patient presents to you similarly. There will be complaint of pain in the bone. There will be weakness of the bone. Because of the weakness, there will be pathological fracture. There will be some deformity on X-ray. If you do the lab investigations, calcium, phosphate, ALP, vitamin D, some abnormality will be given. And then you will be asked to make the diagnosis. And most of the students suffer here because they don't understand that there is a simple mathematical approach to making the diagnosis. And once you've made the diagnosis, you'll understand things. So essentially, this is the medical part of orthopedics. I'll be discussing the orthopedic part of these conditions and these pathologies as well, but mostly it is the medicine part of orthopedics. Okay. With that said, quickly review the constituents of the bone. What do we have? I've told you already. Bone has the inorganic component, that is the calcium and phosphate in the form of hydroxyapatite. That is the majority part of the bone. It has the organic component, that is the osteoid, which has the protein and the cells. Protein and the cells. And what is the principal protein of the bone? The principal protein of the bone is collagen. Yes. And what are the cells that you find in the bone? Osteoblasts, the builders, osteoclasts, the cutters, and osteocytes, the sleepers of the bone, right? So principal component of the bone, the whole bone, is the calcium in the form of hydroxyapatite. These are the things you already know. You also know that osteoblast is rich in alkaline phosphatase, the enzyme. Hence, if there is an increased activity of osteoblast, you will find that ALP will be elevated in the serum. So the function of osteoblast is to synthesize bone, osteoclast is to cut the bone. Physiologically speaking, bone is a dynamic tissue where bone resorption and bone formation is going hand in hand throughout your life to give you that proper shape and strength of the bone, and both of them have to work in synchrony, in a balanced way. Otherwise, there will be either excessive bone resorption, as in certain pathologies, or excessive bone formation, as in certain other pathologies, and both of these are not normal, and hence the bone will not be normal, and hence it will be weak, and hence there will be pathological fractures. Okay? Kuch, did you understand some of this story? So this is the physiology of the bone, and this is how we are going to start discussing and have a dialogue of what this whole topic is all about, right? So let's talk about the components of the physiology of the bone. We are basically talking about the components of the physiology of the bone. Mostly we'll be focusing on calcium because calcium is the principal component of the bone. In fact, 99% of your body's calcium is stored in the bone. So bone is calcium and calcium is bone, and we'll talk about calcium. Right. So for calcium homeostasis, what are the components that basically regulate the calcium in your body? You have parathyroid hormone, you have calcitonin, and you have vitamin D. Now you need to understand the role of these three substances in terms of how they help regulate the serum calcium. Right? How do they do it? So let's understand and quickly review this from the physiology that you have read in your first year. What are the triggers what are the triggers that either increase these substances to, help them execute their action? So what are the triggers for these substances? What is the trigger for calcitonin? What makes calcitonin secrete? Why does the body secrete calcitonin? So whenever there is hypercalcemia, calcitonin will be secreted. So what is the purpose of calcitonin? The purpose of calcitonin is to bring the calcium back to normal. Okay? So it is secreted whenever there is hypercalcemia, and the purpose is to bring the calcium back to normal. That is important. So hypercalcemia, the purpose of calcitonin is to bring it back to normal. Not very important, doesn't happen quite a lot. Hypocalcemia, this is a very important trigger. Hypocalcemia triggers the secretion of parathormone. And what is the function of parathormone? The function of parathormone is to bring the serum calcium back to normal. This is very, very important. Restore the serum calcium back to normal. This is very important. Okay. Now, what about vitamin D? What are the triggers for vitamin D? Vitamin D is triggered by hypocalcemia, hypophosphatemia, and also under the direct influence of hyperparathyroidism or parathyroid hormone. So all of these things trigger vitamin D. And what is the purpose of vitamin D? The action of vitamin D is to restore the serum calcium and phosphate back to normal. At this level, just remember, calcium, hypocalcemia, parathyroid hormone is triggered. This is what I want you to understand. And now you have to understand two important things that trigger parathyroid secretion. So whenever there is increased parathyroid, what do you call it, friends? You call it hyperparathyroidism. Okay, na? You know this, hyperparathyroidism, right? So what is the trigger for this parathyroid hormone secretion? I've told you, decrease in calcium. So hypocalcemia is the trigger for hyperparathyroidism. Okay, right. Now let me ask you this. Whenever there is hypocalcemia and PTH secretion is increased, we call it hyperparathyroidism. What type of hyperparathyroidism is this? Is this primary or is this secondary? Think. Is this primary or is this secondary? Yes, this is secondary hyperparathyroidism because it is under the influence of hypocalcemia. And because of hypocalcemia, it is being secreted. And once it is secreted, the function of parathyroid hormone is to restore the serum calcium back to normal. Okay, there are various methods by which it does it, and I'll explain all of those to you. But please bear with me because I have to give you an overview. I'm assuming you know nothing here, right? Maybe you know a lot, but I'm assuming this right now because I don't know you. So that's why I'm giving you the overview, starting from the basics. So it will do a lot of things to bring the serum calcium back to normal. And once it is brought back to normal, what happens immediately? There is a negative feedback. This is very important, friends. There is a negative feedback. And this negative feedback stops the further secretion of parath hormone. Right? So this is secondary hyperparathyroidism, where there is a hypocalcemia triggering the secretion of parath hormone. Parath hormone brings the serum calcium back to normal by various methods. And once the serum calcium is back to normal, there is a negative feedback inhibiting the secretion of parath hormone. This story hai. Okay. Now, how is this different from primary hyperparathyroidism? In primary hyperparathyroidism, understand that there is no trigger. Listen to me, listen. Everything that I'm talking about right now is written in the coming slides. And I've told you in the beginning itself, everything is written in the slides. I've been teaching since so many years and I've understood that students want notes, everything to be written. And everything is written in the PPT. I just want you to listen to me, understand the concept beautifully, the story of what is going on in the bone. And once you've understood this, you can pause the videos and write the notes because everything that I will teach you will be written in the slides for your convenience. Okay, you trust me on that. Okay, so listen. So what am I telling you here? I've told you there is hypocalcemia, and because of hypocalcemia, PTH secretion is triggered. This is secondary hyperparathyroidism. I'm talking about what is primary hyperparathyroidism. Primary hyperparathyroidism is where there is a disease in the parathyroid gland. There is a pathology in the parathyroid gland, and this pathology is unnecessarily secreting excessive amounts of parath hormone without any kind of trigger, which means that the serum calcium would have been absolutely normal and parath hormone would be secreted because there is a disease in the parathyroid gland. And because of this disease, there is excessive amount of parath hormone being secreted, which increases the serum calcium. Because that's its job, and I'll tell you how. It increases serum calcium beyond the normal. And because this serum calcium is increased, you would assume that there would be negative feedback to parath hormone telling it ki beta, stop. But the problem is, there is a disease in the parathyroid gland. The negative feedback will not have any kind of effect on it. What will happen because of this? There will be excessive amount of serum calcium. There will be excessive amount of parath hormone. Are you understanding? Simply, what does it mean? It means that in secondary hyperparathyroidism, at least there is a negative feedback that can inhibit the secretion of parath hormone once the serum calcium is restored. And in primary hyperparathyroidism, there is no negative feedback because there is a disease in the parathyroid gland. Is this clear? Now let's understand how this parath hormone brings the serum calcium back to normal. Right? How does it regulate that? For that, I want you to look at this diagram. So whenever there is hypocalcemia, right, there is a trigger to increase synthesis of parath hormone. So this is hyperparathyroidism. Which type of hyperparathyroidism? Secondary. Excellent. Okay, secondary hyperparathyroidism. Now, action of parath hormone is in 3 phases. First, it goes to the kidney and activates a very important enzyme. Which enzyme is that? 1-alpha hydroxylase. To activate what? Activate the vitamin D. So it converts the storage form or inactive form of vitamin D into an active form of vitamin D at the kidney with the help of 1-alpha hydroxylase. And once vitamin D is activated, what does it do? It goes to your GI tract. the gut. And what does it do in the gut? It absorbs the calcium and phosphate. But abhi story mein confuse mat ho. Let's just focus on calcium. It absorbs the calcium from the gut and it restores the serum calcium back to normal. And once it does that, there is a negative feedback to parathormone to stop. That is one way of bringing the serum calcium back to normal under the influence of parathyroid hormone. What is the other way? The other way is again to go to the kidney. And in the kidney, absorb the calcium from the urine. And in kidney, whenever there is absorption of something, there always has to be an exchange because kidney, businessman, balance hona chahiye, right? Things have to be balanced. So when the calcium is absorbed, phosphate is excreted. Okay? So calcium is absorbed, phosphate is excreted, and this absorbed calcium will bring the serum calcium back to normal, and once it is normalized, there will be a negative feedback to the parathyroid hormone telling it, bhaiya, bas, enough. Third mechanism with which the parathormone can increase the serum calcium is by going to the calcium bank of your body, that is bone. It goes to the bone, breaks the bone down to release the free calcium. Now here is the interesting thing. If the parathormone has to go to the bone and break the bone down to release the free calcium, can you imagine which cell it needs to communicate with to undergo this kind of action? Think about it. Please don't say osteoclast, because this is a question that was previously asked. Now, by logic, you are assuming, see, the bone has to be resorbed, right? So, resorptor of the bone is osteoclast, so it has to be osteoclast. Logically, you're sound, but technically, you're not. You see, osteoclast does not act under the influence of parathormone. It acts through the action of osteoblast. So this is what happens. Parathormone acts on osteoblast. Right? Parathormone acts on osteoblast. And osteoblast releases a ligand known as rank ligand. And this rank ligand then goes and activates osteoclast, who then resorbs the bone. Are you understanding the cascade here? So parathormone acts on osteoblast. Osteoblast releases the rank ligand. Rank ligand goes to the osteoclast, and then osteoclast resorbs the bone, hence releasing the free calcium that we were talking about. And this free calcium will normalize the serum calcium. And once it is normalized, there will be a negative feedback telling parathyroid hormone to stop secreting. So these are the three mechanisms with which parathormone brings the serum calcium back to normal. Right? And pay attention to what happened in the bone, because there was an MCQ that was asked in AIIMS quite a few years ago. The receptors of parathormone are located on osteoblast, osteoclast, both or none. The answer is osteoblast. Is that clear? Okay. Once you've understood this, let me give you another thing. We have a drug in the market that can inhibit this rank ligand, and that is called denosumab, which also is an MCQ. What is the action of denosumab? The action of denosumab is to inhibit the rank ligand. So imagine if the rank ligand is inhibited, eventually down the line, what is the eventual action? The eventual action is suppression of osteoclastic activity. So whenever you want to suppress osteoclastic activity, you can use denosumab. Okay? Rank ligand inhibitor, denosumab, you've understood. Now, the last thing that I want to discuss here is whenever there is bone breakdown, because bone is a dynamic tissue, the bone will always attempt to heal and repair itself. So whenever there is bone breakdown, osteoblasts will immediately will be brought into action, and their purpose is to synthesize bone. And once they have started to synthesize bone, because they contain alkaline phosphatase, it will be elevated in the body. So serum alkaline phosphatase will be high. Suggesting what? There is a bone breakdown and turnover happening. Turnover means there is a bone breakdown followed by bone formation going on. Okay. So if I ask you here, summarize all of this in the terms of lab findings to me. So if there is a case of secondary hyperparathyroidism, what is the cause of secondary hyperparathyroidism? Tell me. Hypocalcemia, right? At your level, think hypocalcemia only. Because of hypocalcemia, there is secondary hyperparathyroidism. There may be many causes of hypocalcemia. Can you give me one example or one cause of hypocalcemia? Vitamin D deficiency. Rickets. Yes, very good. Rickets. Because of rickets, patient has hypocalcemia, and because of hypocalcemia, secondary hyperparathyroidism. Okay. So in findings of secondary hyperparathyroidism, what will you see in the labs? First, calcium will be low, right? That's how the story started, right? PTH will be high. Very good. Phosphate will be low because it is being exchanged for calcium, right? Very good. alkaline phosphatase will be high because there is bone turnover, bone being broken down and synthesized. And eventually the serum calcium will be brought back to normal. So this is the kind of picture you will see in conditions that have secondary hyperparathyroidism. Don't worry about it. Don't memorize just yet. I will simplify everything for you to understand. So as promised, everything is there in the PPT so that you can make your beautiful notes. Hyperparathyroidism, we have discussed there are two types, primary and secondary, right? And I've told you what is the mechanism with which the parathyroid restores the serum calcium. I've told you that first mechanism is to go to the kidney, activate the 1-alpha hydroxylase enzyme. Second is to go to the kidney, reabsorb the calcium, exchanging with phosphate. The third mechanism is to resorb the bone, and I've talked about how it resorbs the bone. It goes and activates osteoblast, and under the influence of rank ligand activates osteoclast. And we've also discussed denosumab, and we've also talked about the receptors of parathyroid hormone located on osteoblast. We have discussed that. Eventually, once the bone is broken down, there is bone resynthesis. I've told you that. And hence ALP is elevated. That's why ALP will be elevated even in patients who have bone breakdown. I've showed you the lab values of patients in secondary hyperparathyroidism also. All right. Now, how is it different from primary hyperparathyroidism? What will be the lab values of a patient in primary hyperparathyroidism? Contrast this. Let's quickly go back here and contrast this with a patient with primary hyperparathyroidism. What will be the picture here? In primary hyperparathyroidism, story will start with parathormone being excessively secreted without any trigger. Because there is a disease. There is a disease in parathyroid gland. Now, because of excessive secretion of parathormone, what will happen? Kidney will be activated for 1-alpha hydroxylase. Vitamin D will be activated. Excessive reabsorption of calcium. So calcium will start to increase more than normal now. Because at normal level, there is a negative feedback. But here, because it's a primary problem, the negative feedback is not working. So calcium will keep on accumulating. What will happen to the phosphate? The kidney will keep on throwing it out because parathormone is telling, bhaiya, reabsorb calcium as much as possible. So phosphate will keep on going down. And the third is bone breakdown. The parathormone, because there is no counter to it, it is excessively being secreted, it will go and keep on breaking the bone down. So as the bone is being broken down, there will be excessive bone synthesis also. So ALP will also be high. Now, can you notice the difference here? The only difference that you will notice at this stage of your preparation is that calcium will be high in primary hyperparathyroidism. That is where the problems of primary hyperparathyroidism come. And we'll understand that. We'll talk about it later. But as of right now, I just want you to appreciate these lab differences. Okay? So here I'm again showing you works without any negative feedback. Calcium will increase beyond the normal level and the phosphate keeps on getting excreted and the bone keeps on breaking down and hence ALP will be elevated. Okay? So this was a general picture of how the bone physiology in terms of calcium works for you. Now, before I go and start dissecting each condition, I want to give you a general idea to understand what these metabolic bone diseases present to you with clinically. Clinically, the general problems of metabolic bone diseases ranging from osteoporosis, scurvy, rickets, osteomalacia, osteogenesis imperfecta are almost the same. So what are the problems here? What is the story of the patient? What will the patient tell you? Right, that will tell you that this patient has a metabolic bone disease. Usually, because of the metabolic problems of the bones are rendered weak. And when the bones are rendered weak, the weight that you put on the bones will cause break in the bone. And that is why they present to you with bone pain. So these weak bones will present to you with bone pains. And these bone pains are the warning or the cry of the bone telling you, bhaiya, bones are going to break now. And eventually, if there is nothing that you have done, the bones will start to break. This is known as pathological fracture because there is a pathology in the bone that has caused the fracture. This is not traumatic fracture. This is pathological fracture. What will you notice here? Now, based on your MCQs that will be asked, they will show you certain radiological findings. They will give you certain lab parameters that will be disturbed. And those things should help you make the diagnosis because at the end of the day, the examiner is basically asking you the diagnosis. Right? There will be clinical features due to these disturbed lab parameters. Most of the times, and certain metabolic bone diseases have certain unique clinical features that will help you clinch the diagnosis. Okay, so now trust me, if I sit down right now and tell you, did you understand anything? I know that most of you will say, sir, nahi, I did not understand much. It's okay, but this is the thing. I know it's complicated. So my job here is to simplify it for you. So how will I simplify it for you? I have simplified it very easy. Okay, this is what I have done. I said, bhaiya, bone, right? Right. Friends, bone, right? What are the components of the bone? I've told you there is a mineral component, and I've told you that there is a protein component, right? The osteoid. Again, don't have to write down everything. I have a beautiful table prepared for you. Just understand here. I've told you there is a mineral component of the bone, and I've told you there is a protein component of the bone. In the protein component or the osteoid component, we have the cells and collagen. Right? We have the cells and the collagen. Don't write anything. Just listen. So the bone has a mineral component. The osteoid component has the cells and it has the collagen. Right? So mineral component diseases will affect the mineral part of the bone. What do you mean mineral part of the bone? The calcium, the phosphate. So what are the diseases that affect the mineral part of the bone? We have your diseases because of vitamin D deficiency like rickets, osteomalacia, and parathyroid abnormalities like primary hyperparathyroidism. Okay, don't worry about my handwriting. Just listen to me, understand. Everything is there in the table. That is in the next slide. Okay, just understand here. In collagen, I've told you the principal collagen is collagen type 1, and this collagen needs to mature, right? So initially it is a pro-collagen and it needs to become a mature collagen. And we all know which coenzyme helps a pro-collagen become a mature collagen. Which coenzyme? Vitamin C. Very good. Vitamin C. Vitamin C helps in the hydroxylation of two important amino acids. Which amino acids are those? Could you recall from biochemistry? Proline and lysine. Yes, proline and lysine. So hydroxylation of proline and lysine in the presence of vitamin C will give you hydroxyproline and hydroxylysine, right? So this is the cross-linking of the collagen that happens and makes it mature. Now, if you have vitamin C deficiency, what will happen? The collagen will not mature properly. So which disease? Scurvy, right? So we have scurvy here. And what if your collagen is genetically abnormal? It is genetically abnormal. The pro-collagen itself is abnormal. So you have osteogenesis imperfecta here. So you have these diseases like osteogenesis imperfecta and scurvy affecting the bone, but the osteoid part of the bone, not the mineral. So why am I telling you this? Because in these patients, the labs minerals will remain normal. Usually are normal. At least at your level, on your exams, they'll remain normal. So in which conditions labs will be abnormal? Rickets, osteomalacia, hyperparathyroidism. In these conditions, labs will be abnormal in terms of calcium, phosphate, ALP. Whereas in scurvy and osteogenesis imperfecta, the mineral component on the labs will be normal. Okay? Right? Kuch aaya samajhne? Right, don't worry. I'll explain again. Cells, we know that there are two important cells, osteoblast and osteoclast. Most of the pathologies usually occur in osteoclast. Either they can be excessively acting or they can be depressed. If they're acting excessively, means they're resorbing the bone excessively. You have your Paget's disease, right? And if they're not functioning, means bone is not getting resorbed, instead bone is being formed excessively, you have osteopetrosis. Again, don't worry, everything is there in the next slide. Just understand here. Story mein samjho, story mein. So here what is happening? Excessive bone breakdown, think of Paget's disease because of excessive action of osteoclast. No bone breakdown, that is excessive bone formation or thickening, think of osteopetrosis because the osteoclast are not functioning. Right? So we have 1, 2, 3, 4, 5, 6, 7 diseases that we are going to discuss. But very importantly, most of the questions will come from the 8th condition, that is osteoporosis, my friends. Osteoporosis. Now, osteoporosis is a different entity. It is an entity when the volume of the bone decreases. So it's a quantitative problem, and I'll again explain everything in detail, but just understand the overview here. You'll thank me later. So osteoporosis is a volume problem. Bone is normal, it's just that the quantity is less. The food is tasty, you love the food, it's just that mama ne thoda kam banaya, right? So the volume of the bone is less. So it's a volume or a quantity problem. Okay, it has no lab disturbance. It has no collagen problems. It has nothing. It's just that the quantity is less. That's why I've kept it separately. So these 8 conditions are what we are going to talk about in metabolic bone diseases. And as promised, this is the table that will summarize everything for you. Okay? Bone has mineral component. Bone has the matrix component and the cells. In mineral component, what could be the problems? It could be a vitamin D problem or parathyroid problem. So hyperparathyroidism, rickets and osteomalacia patients, they will have lab abnormalities. Collagen problems, either the pro-collagen itself is genetically abnormal, osteogenesis imperfecta, or it is not maturing because of the deficiency of the coenzyme vitamin C, that is scurvy. So these patients, the labs will be normal, the mineral part of the labs will be normal. And cellular pathologies, osteoblasts are usually not the ones that are affected. Osteoclast it is. Either they are increased function, mean excessive bone resorption, Paget's disease, or no function, that is excessive bone formation or thickening, osteopetrosis, and mass or the volume of the bone is decreased in osteoporosis, and everything else remains normal. So this table is a very handy table that will help you make a diagnosis even before you start thinking too much about the question. And that is the whole aim of this exercise. The job of us sitting here is to basically help you make that diagnosis that will help you clinch the MCQ. So again, as promised, everything is summarized here. I've told you mineral problems will occur because of vitamin D or parathyroid problems. If it's a vitamin D problem, it can be rickets and osteomalacia. If it's a collagen problem, it's either because of abnormal collagen genetically, that is osteogenesis imperfecta, or if it is not maturing because of the absence of vitamin C, it is scurvy. If it's cellular problem, it can be either Paget's disease or osteopetrosis because osteoclast is either overactive or is not functioning. And finally, the low bone volume or mass is because of osteoporosis. Let's first start with the most commonly asked one, that is rickets and osteomalacia. So what is the difference between rickets and osteomalacia? Essentially nothing. Rickets occurs before skeletal maturity and osteomalacia occurs after skeletal maturity. For all intents and purposes, they are the same thing. Rickets will occur in children and osteomalacia in adults. Okay. So what is the problem here? The problem here is due to the deficiency of vitamin D, there is hypocalcemia. Right? There is a deficiency of vitamin D leading to hypocalcemia, which again also remember can be a cause other than vitamin D deficiency also for rickets, that is deficiency of calcium itself or deficiency of phosphate also. But none of them are very common, so let's focus on deficiency in vitamin D. So the deficiency of vitamin D is the most common cause of rickets. Now what is the cause of this deficiency in vitamin D? There are many causes of deficiency in vitamin D. Most common is nutritional. Patient doesn't consume enough vitamin D. What are the other causes of vitamin D deficiency leading to rickets? Malabsorption. Patient consumes it, but it's not absorbed. Lack of sunlight exposure, because sunlight activates vitamin D in your body. Lack of sunlight exposure means you're stuck at home, you're not going out, you're stuck in quarantine, or people who cover up their body when they go out, or people who apply a lot of heavy sunscreen to protect them from sun. So sun protecting factor more than 30, if you use, has the potential to prevent vitamin D activation. So keep that in mind whenever you're purchasing your sunscreen. Liver and kidney diseases. Patients who have liver and kidney diseases also may end up having vitamin D deficiency. Why is that? Because vitamin D activation occurs in the liver as well as in kidney. Remember, 1-alpha hydroxylase was the activation of vitamin D in the kidney. So if the kidney is failed, how will vitamin D get activated? Right? And finally, drugs. Certain drugs have direct inhibitory action of vitamin D, or certain drugs are competing with vitamin D for their action. So all of these things eventually down the line will lead to vitamin D deficiency, but the most common is nutritional cause. Patient doesn't consume vitamin D. Right? So that is how rickets manifests or osteomalacia manifests. But before we begin, I want you to understand two important terms. First is osteoid maturation time. Other is mineral opposition rate. What is osteoid maturation time? See, I've told you in the beginning, in the basics, the bone formation is basically an osteoid that is formed with the help of osteoblast, and then the mineral will get deposited on that osteoid to become osteon, that is bone, right? We've read this. So if there is a deficiency of vitamin D, which means there's a deficiency of mineral, which means the osteoid will remain an osteoid, right? It will not mature. So in patients with rickets or osteomalacia, this osteoid will take a lot of time to mature because of deficiency in mineral. So osteoid maturation time will increase. Why? Because of hypocalcemia. Okay, समझ आया? Right. So the second term is mineral opposition rate. What is mineral opposition rate? Means speed. Speed at which the mineral gets deposited on the bone. If the patient has less mineral, what will be the speed of deposition? Less. So mineral opposition rate will decrease in patients with rickets and osteomalacia. Just familiarize yourself with these two terms. Okay, sometimes they can throw this in MCQs. Now tell me, what will be the lab findings of a patient with rickets? You tell me, I've already taught you this. So patient has vitamin D deficiency, which means that his calcium will be low to start with. And whenever the calcium is low, what will happen? Whenever the calcium is low, it will stimulate or trigger parathormone secretion. So which type of hyperparathyroidism is this? Secondary, excellent. Secondary hyperparathyroidism. And what is the action of parathormone? 3 mechanisms. Goes to the kidney, activates vitamin D to absorb calcium, brings the serum calcium back to normal. Right. What is the second action of parathormone? Goes to the kidney, reabsorbs calcium, throws phosphate out. So the phosphate will go down. Right. And the third action of parathormone is to go to the bone, break the bone down, release free calcium, bring the calcium back to normal. And when the bone is broken down, it has to be resynthesized. So alkaline phosphatase will be elevated. So can you summarize all the lab findings of rickets or osteomalacia here? Yes, very simple. Calcium will be low or normal. PTH will be high. Phosphate will be low. ALP will be high. Now, do you need to memorize this? You don't. Right? You have solid foundation of understanding metabolic bone disease now. Now, what about the clinical findings? I'm sure you have read about the clinical findings of rickets since first year of MBBS. You know this stuff, right? The changes in the skull, the changes in the long bones, the changes in the chest. But I'll tell you this. Why do these changes happen? The changes happen only because there is a mineral deficiency. Now, because of the mineral deficiency, the bone is not a mature, strong bone. It's still immature. It's weak. It's mostly osteoid. So this is a soft bone. And because of this soft bone, various pathologies are manifesting. I'm talking about skeletal manifestations. There can be other manifestations also that you will read in medicine or pediatrics. What I'm talking about is skeletal manifestations. So what are the manifestations? You can see changes in the skull, in the chest. What are the changes? Craniotabes. Have you heard of this? Craniotabes, softening of the skull, ping pong skull. This is the earliest change that you will notice in the child. MCQ. Frontal bossing, delayed closure of fontanelles. These are the findings you will see in the skull. What about the chest? The chest, rachitic rosary. There is a costochondral junction, swelling. Swellings at the costochondral junction, swelling between the sternum and the rib interface. You'll understand why do you get these swellings at the bony interfaces in a bit. So there will be costochondral swellings, and these are known as your rosary. Because it's seen in ricket patients, we call it rickety rosary. There is something known as scorbutic rosary also, which occurs in scurvy. We'll talk about it later. Rickety rosary, they are blunt and non-tender. Please keep that in mind because sometimes they ask you the difference between rickety rosary and scorbutic rosary. Pigeon chest, pectus carinatum, prominent chest will be seen in these children as they breathe. And Harrison sulcus, what is this Harrison sulcus? You see diaphragm inserts on the ribs. Right. And it constantly contracts because the muscle has to contract because you have to breathe. The ribs are soft because the bones are soft. And as this diaphragm contracts, the part at which it inserts on the ribs starts to pull the ribs, and hence there will be a bending or a sulcus there. That is known as Harrison sulcus. Okay? So these are the findings. You know all of these findings. Now what about the long bones? As the child puts weight on these long bones, the bones will start to bend also now. But here is a very, very important point. These bending of long bones will only happen when the child starts putting weight on it. And this has been abused as an MCQ. Because if it's an infant or anything less than an infant who's not started to walk yet, the bones will not bend. The bones will not bend. So please keep that in mind. Okay? Only when the child starts to walk and put weight on these long bones, they will start to bend because they are soft. Okay, very important point here. I've marked it here. Now let's understand how they use these terminologies to help you understand what type of deformities or bends that you're seeing in the bone. Before we talk about it, you need to understand 3 terms. What do you mean by coxa, genu, and cubitus? In rickets, we'll only talk about a coxa and genu, but please understand what this cubitus also means. So coxa means hip, genu means knee, cubitus means elbow. Right. Okay, so this is your hip, this is your knee. Now, whatever part distal to it is the one that will decide what type of deformity we are talking about. For example, look at this. This is your hip, this is your knee, this is your ankle. Okay, knee. Knee is genu. What is distal to knee? Your leg. Now, if your leg goes away from the midline, so this is the midline, friends. If it is going away from the midline, we call it valgus. Okay, this is the diagram of normal, so you might get confused here. So let me just not show it over here. Let me show it over here. So this is the midline, and if the part distal to the knee, that is distal to the genu, goes away from the midline, what do you call it? Valgus. Okay, here this is the midline, this is the genu, and the distal part of the genu is coming towards the midline. What do you call it? You call it varus. So what type of deformity will you call it? You will call it genu varus deformity. Okay? Very simple. So just look at which is the proximal joint to the deformity. So the deformity is here at the legs. Proximal to it is the knee. So we call it genu. Legs are going medially towards the midline. Genu varus. If the legs are going away from the midline, valgus. Okay. What about hip? Suppose this is hip. If this is hip, we call it coxa. So distal to hip, the femur is going away. You call it coxa valga. And distal to hip, distal to coxa, if the thigh is going medially, you call it coxa vara. Okay? Clear? Coxa valga, coxa vara, genu valgum, and genu varum. Right. Now look at this proximal part of the femur. Proximal part of the femur. The head of the femur, the neck of the femur, the shaft of the femur. Right. So normally the neck and the shaft of the femur make an angle that is known as 125-degree angle, that is known as the neck of femur angle. Also known as Mikulicz angle, but at your level, don't worry about it. It's neck shaft angle. Neck shaft angle is around 125 to 130 degrees. Now, when I say coxa vara, what will happen to this angle? It will decrease. Are you noticing? So look at this neck shaft. If the shaft has to go medially, if this is the midline, the neck shaft angle will decrease. Right? So neck shaft angle decreased is known as coxa vara. Neck shaft angle increased means coxa valga. So this is neck, this is shaft. And if the shaft has to go away from the midline, the neck shaft angle will increase. So coxa valga, coxa vara. Kuch samajh hai? Did you understand? Genu varum, genu valgum, coxa vara, coxa valga. Let me just erase this and help you appreciate what are the other terms we use to describe these deformities. We'll go back to rickets in a bit, but please understand these terms because we'll be talking about this quite a lot. So whenever the patient has a bilateral genu varum, you call it bonies. And whenever the patient has bilateral genu valgum, you call it knock knees because the knees are knocking into each other. Knock knees. Okay. So bonies, knock knees. Bonies and knock knees. Right. So these are the deformities that you can see in a child with rickets once the child starts to put weight on the limbs. Right. So what will be the clinical findings? In knees, you will notice in patients of rickets, you can have bilateral genu valgum, you can have bilateral genu varum. We just discussed this. But also, rarely, you can have wind-swept deformity. Now, what is this wind-swept deformity? Just listen. So, can you tell me what is the problem here in this child? So, this is the midline, right? This is the knee, right? So, the leg is going towards the midline. Genu varum. Hai na? This is genu varum. What about this one here? Knee, the legs are going away from the midline. This is genu valgum, right? Genu valgum. What about this? This is the midline, friends. In one knee, the leg is going away from the midline, and in the other knee, it is going towards the midline. So one is going towards the midline, other is going away. So one side is varus, other side is valgus. Ye kya hai? What is this? This is known as wind-swept deformity. It's like wind came from the side and caused the deformity. The wind-swept deformity. One side has varus, the other side has valgus. Okay. So all of these findings can be seen in patients with rickets who has started to bear weight on the long bones. But before we proceed further, few MCQs we have to discuss because at the end of the day, that's what we are preparing for, right? To answer MCQs. So there will be MCQs asked around wind-swept deformity. They'll ask you what is the most common cause of wind-swept deformity. If they ask you that, the answer has to be rickets. If they specifically mention children, obviously the answer will again be rickets. But rarely if they ask you, what is the most common cause of wind-swept deformity in adults, then your answer has to be carefully marked as rheumatoid arthritis. Because in adults, rheumatoid arthritis is the most common cause of wind-swept deformity. Okay? This is one set of MCQs. Another set of 6 MCQs you should know for your exam are these. What is the most common cause of bilateral genu varum in children? Okay? What is the most common cause of bilateral genu varum in children? What should you mark? You should mark rickets. If that is not given in the options, then you can go with idiopathic. Okay? So first MCQ. Second set of MCQ. What is the most common cause of bilateral genu varum in adults? What should you mark? Varum, na? You should mark osteoarthritis more than rheumatoid arthritis. So osteoarthritis more than rheumatoid arthritis. Next set of MCQs. What is the most common cause of bilateral genu valgum in children? What should you mark? Turn it around. Idiopathic more than rickets. Idiopathic more than rickets. Then what is the most common cause of bilateral genu valgum in adults? Then you should mark rheumatoid more than osteoarthritis. Remember this. Rheumatoid more than osteoarthritis. The last MCQ. What is the most common cause of wind-swept deformity in children? You know this. Answer is rickets. And in adults, you know this. Answer is rheumatoid arthritis. Okay? Can you handle these MCQs if they ask you around the deformities of the knee? You've understood how to say genu varum, genu valgum, coxa vara, coxa valga. Similarly, if I ask you, can you tell me what is cubitus varus and cubitus valgus, which we will read in upper limb trauma? Can you tell me still? So cubitus is elbow, right? Forearm going midline towards the midline is cubitus varus. And if forearm goes away from the midline, you call it cubitus valgus deformity. So cubitus varus deformity, cubitus valgus deformity. We'll read about this. We'll discuss the pathologies there. Okay? Clear? Hai? Right. So let me show you how these bones start to bend in patients with rickets once they start putting weight on it. So you can clearly see this is bilateral genu varum, and you're noticing this is known as bowing of legs in rickets. Now, another thing you must have noticed when you are preparing or reading about rickets is that the joints will be swollen in patients with rickets, right? The joints will be swollen. There will be swelling around the joints. Now, why is this swelling happening in patients of rickets? For that, again, we'll have to go to our basics of growth plate. Now, what are the layers of the growth plate that we read? Okay, so this is your epiphysis, this is metaphysis, this is diaphysis, right? So far, so good. You've understood this. So what is this? This is the growth plate, right? The physeal plate. What are the layers of the growth plate from epi to meta? Recall this, you know this. Germinal, proliferative, hypertrophic, calcification, ossification. Right. What was the purpose? The purpose was from germinal layer to proliferate, proliferative. In hypertrophic layer, it grows in size. In layer of calcification, it absorbs calcium, or calcium gets in, and then it ossifies and becomes a part of the bone. That's it. This is how the bone grows in length. Now, in patient with rickets, what is the problem, friends? The problem is that this patient has mineral deficiency. There is no calcium. So germinal layer will be fine. Proliferative layer will be fine. Hypertrophic layer will keep on hypertrophying without getting calcified. And when it is not getting calcified, it will keep on getting hypertrophied. So germinal is fine, proliferative is fine, hypertrophic layer will keep on getting hypertrophied. Because there is no calcium here to calcify it. Because the patient has mineral deficiency. So this hypertrophic layer keeps on growing and causes swelling at the joints, because the growth plate is at the joints, at the ends of the bone. That is where you get the swellings. You get the swellings at the wrist, at the elbow, the knee, and the ankles. That is what you will notice in this patient. And when you take an X-ray of this patient with rickets, what will you notice? This is what you will notice. You will notice that the metaphysis, compared to the normal side, has a lot of cupping, has a lot of splaying, widening, and has fraying. And the joint or the growth plate size or space on X-ray is widened. Widening of the growth plate or the physeal plate. Can you notice this on X-ray? There is cupping here, there is splaying, and there is a widening of the growth plate. Look carefully. Let me erase this. There is cupping, splaying. Again, look at this X-ray. Cupping, splaying, and there is widening of the growth plate. Okay? So everything that I've said, I said slides will be there for you to copy. So layers of the physeal plate, you should know. I've told you this. Hypertrophic layer keeps on expanding without the mineralization, causing what? Widening, cupping, splaying, and fraying of the growth plate. Now here is the interesting thing. What happens if you give this patient the thing he needs? What does this patient needs now? He needs vitamin D because he has rickets. Once you give him vitamin D, the vitamin D will absorb the calcium, and this calcium will start immediately to go to the hypertrophic layer. And once this hypertrophic layer becomes the layer of calcification, and then it starts to become a part of the bone as in layer of ossification, the osteoclast will now immediately come in and resorb this abnormal swelling. Because osteoclast, remember, can only act on normal bones. It cannot act on bones that are deficient in mineral or are abnormal. Okay? It cannot. Because it doesn't understand it to be a normal bone. So these swellings in patients with rickets will disappear upon treatment with vitamin D. So most of the deformities that you will read in patients with rickets are reversible upon treatment. So please keep that in mind. The osteoclast cannot act on improperly ossified bone, and most deformities are reversible because once you start the treatment, the osteoclast can resorb the properly ossified bone, and hence these deformities disappear. So say this is a patient with rickets who comes to me and I have started giving him vitamin D. Now the bone will start to heal, the deformities will start to go away, the swellings will come down, and what will be the radiological picture now? This will be the classical radiological picture. The hypertrophic layer will start to get calcified, so you will notice a thick band of calcification. This wide thick band of calcification on the metaphysis is known as white line of Frankel. What does it suggest, friends? It suggests that this patient of rickets is getting treated. The bone is starting to recover. Right? This is a very, very important sign. It's a very, very important sign, and it is the best method to assess the healing of rickets. Okay, labs will improve. See, once you start giving patient vitamin D, calcium absorption will increase, and once calcium starts to normalize, parathyroid hormone secretion will come down, and once parathyroid hormone secretion comes down, phosphate will come back to normal, and bone breakdown will stop, and ALP will also eventually down the line come back to normal. But early findings will be picked up on X-ray. So that is why X-ray is something that helps us assess the healing or recovery of patient in rickets. ठीक है, समझ आया? So did you understand this healing rickets? Did you understand cupping, splaying, fraying, and swelling? Did you understand why there is swelling? Did you understand how remodeling will improve or treat the deformities that are seen in patients with rickets? So finally, let me tell you the treatment in broad perspective or broad spectrum, how we treat the patient with rickets. Specific treatment of the dosage of vitamin D, I'll discuss after osteomalacia. But the idea here is this. Whenever the patient comes to you with these deformities, say genovarum and genovalgum, you can just give splints and start the patient on vitamin D treatment, because like I said, most of the deformities are reversible. Very rarely, if the patient requires a surgery, MCQs will be asked, when should you go for this deformity correction? So the algorithm here is very simple. If the patient comes to you young, at a very young age, say 2 years, 3 years, what does it mean? It means the growth of the child is left. There is a lot of potential for the child to grow. Right? He's still very immature. Now, I told you in children, there is a lot of good remodeling potential. So if you treat the patient, as the child grows, there is a potential to remodel and the deformities will correct over time. So there is no need for surgical intervention. Just treat the patient with rickets with vitamin D. Now, what if there are deformities that are persistent even after skeletal maturity? Or if the child or the patient has skeletally matured or is very close to skeletal maturation? If he's very close to skeletal maturation or its skeleton is matured already, obviously there will be no remodeling now because his growth has been achieved. If his growth has been achieved and there is a residual deformity that requires a surgical correction, then how will you assess whether the bone is suitable for correction or not? Why am I telling you this? Because I've told you, in patient with rickets, the bones are soft and you don't want to operate on a soft bone. You want to operate on a normal bone. So how do you assess that this patient's rickets has completely recovered, and since he's a mature skeleton, there is no potential to remodel the deformity, so only intervention right now is surgery. So go and operate and correct the deformity, but make sure that the bone is fine. How do you assess that? You look for serum alkaline phosphatase. If serum alkaline phosphatase has normalized, it means the problem in the bone has ended, and since it is ended, friends, now is the time for osteotomy. So general idea kya hai? If the child is young, has potential to grow, medical management should suffice even with deformities. If the child is old or the age is not mentioned, then you can go for corrective osteotomies. But only after the bone has become normal. And how will you know whether the bone has become normal or not? Look at alkaline phosphatase. If alkaline phosphatase has normalized, it means the problems of the bone are gone. Okay? समझ आ गया? Simple story hai, right? Few MCQs are there in the market. You might get confused. If the child is 2 or 3 years old, you don't have to go for osteotomy. Medical management is usually fine, would suffice. If the age is not mentioned, or if the patient is close to skeletal maturity or skeletal maturity has been achieved, then you can go for corrective osteotomies only when the bone physiology is normalized. And how will you assess that? By looking at serum alkaline phosphatase. Now let's talk about osteomalacia. Now osteomalacia is the same as rickets, only that it occurs in population after skeletal maturity, mostly seen in females, in young people. They also present you with polyarthralgia, bone pains, and proximal myopathy. And all of this is because of calcium deficiency in the body. Right? None of that is important for us. The bony manifestations, these are the things that are important for us. So what are the deformities that you will notice on X-ray? You have something known as milkman zone, loser zone, right? Milkman's loser zone, pseudo fracture. So what are these? Now, to understand what these are, listen to me. You see, bones have become soft here because of deficiency in the mineral. Now, since the bones are soft, they are so soft that the pulsations around the bones, the vessels that pulsate or the arteries that pulsate around the bones, can cause stress fractures to the bone. And so these stress fractures down the line will heal with callus formation, right? Any fracture that will heal requires callus formation if it's healing with a callus. Now, if you recall, callus is basically cartilage, and this callus requires mineral to be deposited in it, and it becomes a bony callus. Now, in these patients, because there is a deficiency in the mineral, there is this callus which is deficient in mineral. And on X-ray, you will notice these loosened zones in the bone. Now, these loosened zones are usually perpendicular to the long axis of the bone. So, say this is the long axis of the bone. These loosened zones are perpendicular to the long axis of the zone. Perpendicular to the long axis of the bone. So, this is what is your milkman's fractures or loser zone or pseudo fractures. These are transverse bands of rarefaction. Rarefaction means lucency, perpendicular to the long axis of the bone. And you have understood why it occurs. And the most common location for such fractures is the neck of femur, particularly on the medial side of the neck of femur. Other sites you can get in clavicle, ribs, scapula, pubic ramus. Okay, but the most common site is neck of femur. But please also remember that these loser zone, milkman fracture, pseudo fractures are not pathognomic of osteomalacia. It is seen in all these other conditions as well. Now, before we proceed further, let me ask you, why did it get the name loser zone? Okay, loser zone. Because there is a loss in the calcium of the bone? No. It is because of the person who described this was called loser. Right? His name was Emil Loser. Right? What about milkman's fracture? Why is it called milkman's fracture? Because these are the people who don't drink milk. The person who described it, his name was Milkman, Jeffrey Milkman. All right. So these are the names. These are some fun facts about why they got this name that I wanted to share. Now, what about the other deformities that you will see in patients with osteomalacia? Because the bones are soft, the pelvis will start to bend. There's something known as triradiate pelvis. It will be bent like this. Trefoil pelvis, pelvis in the shape of a trefoil leaf. And protrusio acetabulae, the head of the femur, will protrude into the acetabulum. That's how the acetabulum has become so soft. You can clearly see that the head of the femur here is protruding into the acetabulum. This is known as protrusio acetabulae. These are seen in patients with osteomalacia. Also, one more deformity that is not exclusive of osteomalacia is champagne glass pelvis. That is also seen in osteomalacia, but it is also seen in achondroplasia. Sometimes they ask you this question. Champagne glass pelvis is seen in, it's mostly achondroplasia, but it is also seen in osteomalacia. Now, how do you treat osteomalacia patient? Again, give the patient vitamin D. In fact, how do you treat rickets patient? Give vitamin D. Now comes the treatment of rickets and osteomalacia with specific vitamin D. We have a regime for it. We call it STOS regimen. And there are many ways of giving it. The three popular methods of giving it is 3 to 6 lakhs international units, deep intramuscular oral, a single dose, a stat dose. That would suffice to treat a patient with vitamin D deficiency. Or you can give a daily dose of 2,000 to 5,000 international units for good 2 to 3 months. Another option is a weekly dose of 50 to 60,000 international units, weekly ones for good, again, 2 to 3 months. That would help. I prefer the weekly dose because the compliance is easy. You tell the patient to take this tablet or capsule or sachet with milk every Sunday or every Friday based on how they feel. And that's a weekly dose and compliance is good. That's how I treat patients with rickets or osteomalacia. Now, apart from this, there are certain tumors that induce osteomalacia in patients, and that has been asked as an MCQ a few years ago. So these are the tumors that induce osteomalacia. You can memorize this and be ready for the exam MCQ. Now, moving on to scurvy. Scurvy is vitamin C deficiency, and obviously you know what it is. Vitamin C deficiency, absence of vitamin C will not allow for the procollagen to become mature collagen. So there will be an abnormal or weak collagen. So collagen majority defect because of vitamin C deficiency. Obviously, since it's a collagen problem, labs are usually normal. And since it's a collagen problem, it will not only be limited to bone. It will be wherever there is collagen. So the problem will be in the endothelium, in the skin, in the bleeding gums, wherever, right? So the manifestations, I have put it in a table here. The manifestations can be in the bone, and we'll focus on that because orthopedics. The other places, mostly endothelial, that is blood vessels, you will see bleeding gums. You'll be seeing bleeding at the costochondral junction. The scorbutic rosary we talked about, which is different from rickety rosary. Rickety rosary, is non-tender and blunt. This will be opposite of that. This will be tender and sharp. In the bone also, you will notice bleeding under the periosteum, so subperiosteal hemorrhages here. Now, in the bone, what are the various findings that you will notice? So let me show you an image here. This is an X-ray of a patient with scurvy, and this is an X-ray of the knee joint. What will you notice? You will notice changes in the diaphysis, metaphysis and epiphysis. So in diaphysis, what you'll notice? You'll notice since the osteoid is not proper, it will look like a ground glass. So ground glass or hazy. And the cortex, the pencil thin cortex, the term that they have used to describe this, pencil thin cortex, again not very important. Under the periosteum, there will be hemorrhages, subperiosteal hemorrhages, and because of this there will be pain in the child on moving the limb. So this child will be hesitant to move the limb, which will look like paralysis to the parents. But is it true paralysis? No, it is pseudo paralysis. And so this is a term that you will come across quite a lot. Pseudo paralysis will be seen in conditions that cause pain on movement, so the child will be hesitant to move. For example, osteomyelitis will also present with pseudo paralysis, or septic arthritis will also present with pseudo paralysis. One of the causes is scurvy, where there is subperiosteal hemorrhages, because of which the patient doesn't want to move the limb, and it looks like paralysis, but it is not true paralysis, it is pseudo paralysis. Now in metaphysis, what will you notice? Very important, white line of Frankel, which we already read in healing rickets. This white band that you will notice is known as white line of Frankel, which is more characteristic for scurvy, but trust me, it is not only seen in scurvy, it is seen in so many conditions: healing rickets, congenital syphilis, plumbism, leukemia, all of them. But at this level of your preparation, just assume that it is in scurvy and healing rickets. Then there is something known as scorbutic zone or Trümmerfeld zone. It's this lucent zone, this lucent or dark zone, right? And then there is Pelkan spur. Pelkan spur are these spurs in the metaphysis at the edges. Okay, so these are Pelkan spurs. And in the epiphysis, the most important finding is in the epiphysis, there is a sclerotic rim around the epiphysis. This is known as the Wimberger ring sign, and this is the one that usually helps us make the diagnosis of scurvy. Two important things: one, in scurvy you will notice that Wimberger ring sign, and second, labs in terms of mineral should be normal. Obviously the other findings are bleeding gums and what you know all that. The treatment of scurvy is give patient vitamin C, right? Give patient vitamin C. Now there is a condition known as Barton's disease. What happens in Barton's disease? The patient has both vitamin C and D deficiency, and he presents to you with rickets and scurvy features overlapping each other. And the reason I'm mentioning Barton's disease here is because there is a very common fracture that occurs at the distal end of the wrist. That is a distal end of the radius, intra-articular fracture. That is known as Barton's fracture. And we'll read about that in upper limb trauma. Don't get confused with Barton's fracture and Barton's disease. That is the reason I have mentioned that here. Now the next condition I want to talk about is hyperparathyroidism. This is primary hyperparathyroidism because secondary hyperparathyroidism we've already talked about in terms of rickets and osteomalacia. So primary hyperparathyroidism, when there is a problem in the parathyroid gland itself, and the most common cause for that is actually a tumor, that is an adenoma. Adenoma of the parathyroid gland is the most common cause of primary hyperparathyroidism. Secondary hyperparathyroidism is usually because of, say, hypocalcemia, vitamin D deficiency, renal failure and liver failure. Why renal and liver failure? Because I've told you vitamin D does not get activated in renal and liver failure. So there will be vitamin D deficiency, hence hypocalcemia, hence secondary hyperparathyroidism. We are not talking about secondary now. Secondary ho gaya. We have read that. We're talking about primary hyperparathyroidism. Here there is an adenoma in the parathyroid gland causing excessive secretion of PTH. So story here is that there is excessive secretion of PTH, and because of excessive secretion of PTH, can you imagine what happens? There will be excessive vitamin D activation. Okay, so calcium absorption will be high, so calcium will increase in the body. Okay, goes to the kidney, absorbs calcium and throws out phosphate, so phosphate will go down. Goes to the bone and keeps on breaking the bone down. There is no negative feedback to PTH now. It will go on and keep on breaking the bone down, right? So PTH is high, very, very high in fact. And when there is excessive bone breakdown, ALP will also be high. Okay, so this is the finding of primary hyperparathyroidism. Lab finding, you know this. We are interested more in the bone breakdown that is happening. So because of this PTH, what are the various bones that are getting broken down? We have skull that is getting broken down, which gives you the classical salt and pepper skull. or pepper pot skull. We have resorption of calcium that is there around the teeth in a layer known as lamina dura. That resorption of calcium will occur, hence the teeth will become loose. You have resorption of the bones of the finger, resorption of the phalanges. This is very, very pathognomic, and I'll go in details in a bit. These resorptions happen under the periosteum, subperiosteal resorption. This is what happens. And there will be resorption of bone. There will be cavities in the bone because bones are being broken down. This is known as brown tumor, and I'll tell you why it is called brown tumor and why it is not a tumor, right? And all of this happens because there is no negative feedback. There is no negative feedback because calcium has increased beyond the normal capacity and it's trying to inhibit the parathyroid hormone, but PTH is adenomatous. There is a tumor there, so it keeps on secreting. So there is excessive bone breakdown, and because of there is excessive serum calcium in the body. So the end manifestation of primary hyperparathyroidism is two things. Number one, excessive calcium in the serum, and number two, excessive bone breakdown. And whenever there is excessive bone breakdown, I've told you we have salt and pepper skull, resorption of lamina dura, subperiosteal resorption of phalanges, and brown tumor. And because of excessive serum calcium, what will be the manifestation? You know this. Have you heard of that mnemonic? Bones, stones, groans, and psychiatric overtones? Yes. That excessive serum calcium is what causes bones, stones, groans, and psychiatric overtones. So what is this? Bones, stones, groans, and psychiatric overtones? Painful bones because the bone is being broken down. Renal stones because of calcium reabsorption. Abdominal groans, right? Abdominal groans because of motility disturbances of the GI tract. And psychiatric overtones because of calcium disturbance and the cell membrane level, there is neurotransmitter movement abnormalities, which is causing you depression, fatigue, anxiety, and all these things. So, psychiatric overtones. So, these are the other manifestations of increased serum calcium that occurs in primary hyperparathyroidism. Lab finding, I'm sure all of you know this by now. PTH is high, so calcium will be high, phosphate will be low, and there will be high alkaline phosphatase. So, let's go into the details of what is this salt and pepper skull. So, salt and pepper skull looks like you have put both salt and pepper at one place. So there will be these black dots, tiny black dots here. So salt and pepper skull. Subperiosteal bone resorptions. This is very pathognomic of primary hyperparathyroidism. So bone starts to get resorbed under the periosteum in the phalanges. But please remember, it usually occurs more on the radial side. So look at this. This is the radial side. This is the ulnar side. This is the ulnar side. So this is the radial side for this hand. This is the radial side for this hand. And what are you noticing? Subperiosteal resorptions. On which side? The radial side. Okay, very, very pathognomic. So if they show you an X-ray where there is subperiosteal phalangeal resorption on the radial side, you should think of primary hyperparathyroidism. Okay, and the last bony change or the abnormality I told you was brown tumor. What is this brown tumor? You see, bone is being resorbed. So bone is being resorbed. And as the bone is being resorbed, there is this cavity that is formed. And since this is a potential space, blood collects here. And what happens to blood? Blood is hemoglobin. And once hemoglobin starts to break down, it becomes hemosiderin. And hemosiderin gives you the brown color. That is what it is. So there is a cavity filled with brown colored fluid. That is blood. That is hemoglobin broken down into hemosiderin. And you will see these cavities in the bones. That's why it's called brown cysts. But it's a misnomer. It's not a brown tumor. It's not a tumor. It's seen in primary hyperparathyroidism. Other names for this is osteitis fibrosa cystica. You can remember that. And von Recklinghausen's disease of the bone. You can clearly see this cavity here. Cavity in the bone. This is what your primary hyperparathyroidism. And what is the treatment of primary hyperparathyroidism? If it is because of an adenoma, go and remove the adenoma, surgical excision. Right? Don't worry about it. Now, the last thing in terms of parathyroid hormone I want to discuss is very important is renal osteodystrophy. This is seen in patients who have renal failure. So what is the story here? What is this renal osteodystrophy? This is a patient who has renal failure. Okay, kidney fail hai. Kidney fail hai. So if kidneys failed, what are the problems you will notice? First problem, vitamin D will not get activated, right? Because 1-alpha hydroxylase will activate vitamin D in the kidney. So vitamin D deficiency ho gaya. So vitamin D deficiency, first problem. Right. Second problem, since kidneys failed, reabsorption of calcium is not possible. So calcium will be low because reabsorption is not possible. So calcium will be low. And what about phosphate? Phosphate will be high. Yeah. So please remember this one very, very important point. First time I'm telling you phosphate is high here. So calcium is low, phosphate is high, vitamin D is deficient. So since calcium is low, what will be triggered, friends? We know this by rule, by law. Whenever there is hypocalcemia, there is secondary hyperparathyroidism, right? So PTH will increase. Don't worry, I have slides ready for you to copy. Don't worry, PTH will increase. Now, what is the action of PTH? To restore the serum calcium. So how can it go about doing it? 3 mechanisms. First mechanism, go to the kidney, activate vitamin D. But kidneys failed. Since kidneys failed, no activation. One pathway wasted. Second pathway, go to the kidney, reabsorb calcium, throw out phosphate. Kidneys failed, cannot reabsorb calcium. Second pathway gone. Third pathway is left, the only pathway where this increased PTH will go and break the bone down. So this will take the bone, break the bone down to release the free calcium. Yes, finally. And as this serum calcium tries to normalize, since kidneys failed, cannot reabsorb calcium, it throws it out. It throws it out. Your kidney is sabotaging your bone breakdown. But PTH keeps on working. So it goes to another bone, breaks the other bone, but calcium gets wasted out. It goes to other bone, breaks it, but calcium gets excreted out. This PTH keeps on breaking the bones down to increase the serum calcium, but alas, serum calcium doesn't increase. So this leads to destruction of bones. That is why it is called osteodystrophy, and this occurs because of renal failure, renal osteodystrophy. समझ आया? Right? Understood how simple it is? Now in this patient, can you tell me what will the lab findings? Calcium will always be low, PTH will always be high, phosphate will be high, and since there is bone breakdown, bone formation has to occur, ALP will be high. Right? Write it down. Calcium will be low, PTH will be high, phosphate will be high, and ALP will be high. For the first time I'm telling you, phosphate is high. And there is only one radiological finding that you need to remember for renal osteodystrophy. It is called Rugger-Jersey spine. Please remember this. This is direct MCQ. Rugger-Jersey spine. You will notice that there is destruction of bone just under the end plates. So the end plates will appear more dense or sclerotic compared to the vertebrae. So this looks like Rugger-Jersey spine. These are the t-shirts of rugby players who wear this jersey. It's called Rugger-Jersey. Okay. So Rugger-Jersey spine. Okay. Now before I close this topic of parathyroidism, whether it's primary hyperparathyroidism, secondary hyperparathyroidism, or renal osteodystrophy, I want you to fill this table with me and tell me what you think is the lab finding, so that on the exam, when questions like these come, you should be in a position to make your own diagnosis without me. Okay, okay. So primary hyperparathyroidism. What is the problem here? There is an adenoma, right? Because of which there is excessive secretion of PTH. Okay, first point, which will increase absorption of calcium in the body more than normal. More than normal. What else? It's absorbing calcium, so what will it throw out? Phosphate. And since it's increasing the serum calcium, it is breaking the bone down, and whenever the bone is broken down, it has to be resynthesized, so alkaline phosphatase will be elevated. So this is the lab picture of primary hyperparathyroidism. What about secondary? Here the story starts with low calcium, PTH increases, and it absorbs the calcium, throws out phosphate, brings the calcium back to normal, breaks the bone down, and once the bone is broken down, ALP will be elevated. Okay? So far so good? Right. Now in renal dystrophy, what is the story here? Kidneys failed. So calcium is perennially low. And when calcium is low, PTH is high. And since the kidneys failed, the phosphate cannot go out, so phosphate will be high. And PTH is breaking the bone down, and whenever there is bone breakdown, ALP will increase. Okay? Samajh aa gaya? Right? So this is the picture of primary versus secondary versus renal osteodystrophy.